tell us how health system managers and implementing agencies who work with community health workers can monitor and address this effects of gender on the community health workforce, and perhaps with practical examples from your work.
Yeah, thank you. I think it's a really important topic to discuss because the community health worker role, within that there is the opportunity to transform gender norms. Community health workers hold a respected position within communities, so they just need to be supported to be able to make that change. So I think firstly I'll give like 3 overview reflections, and then I can give some more practical examples. So firstly, be reflexive and try and reflect a lot on the community health workforce and the power dynamics that are occurring. You can set up safe spaces for community health workers to be involved in those reflections, and perhaps separately as men and women. Also to involve community health workers in decision making and programming, so that their views are captured and there's space for them to input. And I think that also, when we say that, I think it's around 70% of community health workers are women, that's also, an empowering thing to bring them into the decision-making process. But it's kind of not enough just to have that space. You have to be aware of the power dynamics in the room. So, for example, in Ethiopia, the health extension workers are sometimes allowed to occupy a position in the Kabele cabinet, but the power dynamics in structures in the room mean that there isn't really the opportunity for them to freely voice their concerns. So yeah, thinking about involving community health workers in county and community decision making. I think evidence from Reach Out in Kenya showed that community health workers felt slightly left out of that process, so giving them that platform. And then also not treating community health workers as a homogenous group. I'm sure that the term intersectionality has already been brought up in this series, but thinking through how individual circumstances converge in the contexts that you're working in. So an example I can give from Mozambique was that I was doing some work in the south, and men were often leaving the program to join mining opportunities in South Africa. And so it was like, oh, well, all the men are leaving, but actually when you broke it down, a lot of the younger women were also leaving because they had that ambition. So it wasn't, and actually some of the older men. So there was this real impact of generation there as well, kind of influencing alongside gender. And obviously if you're implementing any changes, then you want to be able to monitor it. There is a real gap in the evidence in this area of things that work and things that don't work. And if you're implementing something new, there's probably going to be some unintended consequences. So making sure that you have a system in place to capture those changes so that others can learn and adapt. So, for example, the training in Mozambique that I mentioned earlier, that's 4 months long. If you were to break that down and do more modular training, so that, you might do a week and then come home and do a week, and that might make it more feasible. It would be beneficial to assess after you've done that, did that change the number of women in the health workforce? Because I should have said that in Mozambique, the goal was to bring more women into the community health workforce because they had more men. But actually that wasn't the case in the south because the men were leaving. So there's, geography, there's gender, there's generation, they're all influencing. So yeah, so to assess whether that changed the number of women coming in and whether that had any benefit on the populations that they then serve. So to think about some of the more practical things that we can do to support the gendered effects. There are frameworks that exist. So we developed one as part of Reach Out, and it just is a conceptual framework really that maps out the touch points that you might want to consider from the health system, the community, and the individual, how that plays out. And I think I've also shared with you a document that was developed based on the WHO guidelines to make it more gender equitable. But some things might be, so if you're thinking about selection of community health workers in the community, are there particular barriers for men or for women? If you've got community members involved in the selection and it's a paid position, does that mean they're going to automatically perhaps put forward a man because he's a breadwinner and therefore, you know, more deserving of paid work? Are there literacy requirements that might exclude women, knowing that women, you know, have a lower literacy level in some contexts? So just thinking through those things and then making sure that you've got allowances or quotas or preferential selection to kind of achieve gender parity or whatever the goal of the program is. Coming back to the training example, so obviously being away for a long time can be challenging for both men and women for different reasons. So if you do modular training, it can be good to do training away from home, I should say, because, you know, often women in particular perhaps are free from the distractions of their home responsibility, so they are able to sort of focus and build a camaraderie, and that's, you know, that can be beneficial. So it's not to say don't do it, but if you do it, perhaps do it modularly, perhaps think about providing on-site childcare, and also ensuring appropriate facilities for menstrual hygiene disposal, and, you know, more practical things like that that might have a differing impact on men versus women. Another example I think that came from India that worked very well was women were often tasked with attending mothers at night for delivery and taking them to a health facility. But there was nowhere for them to, you know, they weren't allowed in the delivery room, and then there was nowhere for them to be. So they created safe spaces for them to stay overnight, because obviously safety is also kind of a worrying emerging concern as well, that a lot of female community health workers are at risk of sexual and gender-based violence sometimes. And so we want to ensure that we're obviously protecting this group as much as possible. And I think some of the other recommendations that I've heard again around safety have been, and it's context dependent, but perhaps male and female pairs. I think in Tanzania that work well, not only for safety, but also guarded against that ulterior motives thing that I mentioned. So yeah, and then a crucial thing underpinning all of this is obviously payment, remuneration. You know, if you've got a predominantly female health workforce and you're not paying them and you're wanting them to work freely, then you're reinforcing that women's work is less valuable, it's more pliant, it's able to fit in around childcare and domestic responsibilities, and that, you know, has a broader impact on gender transformation and of course the empowerment of women. Transport provisions, thinking those through. So I mentioned about motorbikes and quad bikes. You know, if you're providing transport, be it a bicycle, a motorbike, a quad bike, you know, is it appropriate for both genders, and how, you know, what does that look like, and do you need to think of that through a bit more, and or do you need to get you know, community buy-in first, or things like that. And having, obviously promoting a zero tolerance for sexual harassment. I mentioned about working in pairs, career progression. So we spoke a little bit about how women's limited mobility might be stopping them from becoming a supervisor. Likewise, perhaps if they have a less literacy, that would also be a barrier for their career progression. But also, you know, having a role model, seeing women and men as supervisors can do wonders. You know, not just having all male supervisors, like seeing yourself in that role and creating opportunities. So if literacy is a barrier, can we create an opportunity where women can, and men, of course, can, have some literacy training so that they can then progress to that next step. And perhaps having, I heard of an example of female mentors that worked well. And creating educational opportunities to upskill and progress to the next level. The other thing would be that I've seen worked well would be preferential selection of qualified women into a supervisory position until gender parity is reached. Obviously, they have to be qualified, but preferentially selecting women. Provision of health posts in communities can also be impactful, because if there is no health post, then women and men may have to travel around. Whereas if you've got a health post, it's a safer space that women can go to and act as a supervisor without having to put themselves at risk or whatever it is from travel. And then, of course, like those are all very practical things, and they all kind of work around existing maybe harmful gender norms. So within that, we obviously want to work towards, transforming those. So whilst those make allowances for some of those things, also thinking about sensitizing community members as to, the struggles that men and women are facing, and having village elders, if they're involved in selection, having them brought into that process so that everyone's working towards the same goal. Yeah, so I think those are just some examples. I'm sure there's many more, but hopefully that's okay.
Thank you very much, Rosie, for joining us and for the very helpful and practical tips that you have provided us today. Rosie's email is on your screen at the moment. Please reach out to her if you have any follow-up questions or want to learn more about her work or how to address gender within the community health workforce. Please be on the lookout for more sessions from this learning series, and see you during the next one.
Thank you so much for having me. It's been a pleasure.